Merci beaucoup. Merci beaucoup de m'avoir invité pour participer à cette conférence. C'est un grand plaisir d'être ici à Bordeaux avec vous. Malheureusement, je ne parle pas beaucoup en français, donc il est nécessaire de vous présenter la suite en anglais. Excusez-moi. Thank you, Christophe, and your colleagues for this very kind invitation to visit Bordeaux and to participate in this very exciting conference. Greetings from Halifax, Nova Scotia. If you don't know where Halifax, Nova Scotia is, it's this small little peninsula of land hanging on to the side of North America, a very large continent. But there is a connection between France and Nova Scotia, because on the east coast of Nova Scotia, here you can see what is referred to as the Port Royal National Historic Site, which was established and founded by de Champlain in 1605. And this was before the establishment of the colony in Quebec, which remains, of course, the bastion of French Canada. So Nova Scotia had this colony, which only lasted a few years. And at least it is claimed on the Nova Scotia website that it was the first European settlement north of Florida. Champlain went on to discover Quebec, and the fortress at Louisbourg in Cape Breton Island was established subsequently. So when you come to Nova Scotia, as you must, you should visit Port Royal. These are my disclosures. I should add here that I also speak on behalf of the Nova Scotia Tourism Board, as you've seen. But apart from that, everything you will hear about this morning will be peer-reviewed funding from our federal funding agency. So what I hope to do over the next 40 minutes or so is to review with you a classification and an attribution mechanism for all of the neuropsychiatric events that occur in our lupus patients, to very briefly touch on immunopathogenic mechanisms as an approach to diagnosis and treatment, to share with you some of our recent data related to neuroimaging, particularly as it relates to functional MRI, and then to review at a very high level some clinical outcomes with current standards of care. Because in contrast to many other areas of lupus, nervous system lupus has not been subjected to the same rigor of clinical trials as we have, for example, in lupus nephritis. So a lot of our information or treatment strategies are translated from the treatment of other organ manifestations of lupus, and outcomes, our data comes largely from observational cohort studies. So the first recognition that the nervous system could be affected by lupus has been attributed to Kaposi or to Osler. You can decide which one gets the credit, but it's curious that when you review their seminal publications, and where they give very detailed descriptions of individual cases, how frequently infection appears as the more likely cause of the nervous system disease. In that era, it was often tuberculosis. But it's worth remembering that in lupus patients today, we still have to remember infection as a possibility in the differential diagnosis rather than assuming it's a manifestation of lupus. In the most recent classification criteria for lupus, which was a joint effort through EULAR and the American College of Rheumatology, seizures and psychosis, which ironically were the two manifestations that were in the previous 1987 ACR classification criteria, have had delirium or acute confusional state added to it. But of course, there are many other potential manifestations of nervous system lupus. This is by far and away the most comprehensive classification, looking at 12 central and 7 peripheral nervous system manifestations that was designed by the American College of Rheumatology in a publication in 1999. Now, this is not meant to imply that every one of these features, if they occur in a patient with lupus, is necessarily a manifestation of lupus itself. This was an effort to provide some uniform criteria around the classification, to provide some guidance on investigation and diagnosis, and to recognize that one has to always go through an attribution step before determining whether any of these manifestations are a feature of lupus, because it does include very common things such as headache and quite rare things such as psychosis. And I'll show you some effort that we've made to try to address this. So some of the data I'm going to show you comes from the Systemic Lupus International Collaborating Clinics, which has established an inception cohort followed now for almost 20 years. This is an international effort. France is represented, Laurent in Strasbourg, and there's a center in Paris as well. Bordeaux, not yet, but in the future perhaps. And the inception cohort that was established was used to study a number of outcomes, including nervous system disease. The cohort had over 1,800 patients, predominantly female. These were relatively young individuals, predominantly Caucasian, but other racial and ethnic mixes as well. At the enrollment into the cohort, the mean disease duration was just under 6 months. So these are people with early clinical disease at least. And what I want to draw your attention to is at the bottom of the slide, if you apply the ACR classification criteria, so that would be just seizures and psychosis, at enrollment, 5% of patients or 4.8. But if you apply the ACR case definitions across the board, you come up with a 30% frequency. And over 5 years, this increases to 47%. So what are these manifestations? Well, common things being common, headache rises to the top because headache is a common feature, especially in women, but the other features are represented as well. But applying some attribution criteria, and I won't go into the details as to how these were derived, but we had some consensus around how to determine attribution within the SLIC cohort, and decided on 2 attribution models of different stringency, so-called Model A and Model B. Model B includes everything that is in Model A. And this slide is meant to show you that for some manifestations, they're always due to lupus. Some manifestations are never due to lupus, but for the majority, there are some patients who have the feature related to lupus and some due to other cause. Another group which has developed attribution models is the Italian rheumatologists, and they have developed the Italian algorithm, which is similar to the SLIC decision rules, except they've added a 4th criterion and have weighted the criteria so that you come up with a numerical score. And what this slide shows you is that a score of less than 3 makes it very likely that that particular attribution is not due to lupus. A score of 7 or higher has a reasonable chance of it being due to lupus. But in between, there's this area of uncertainty, and that is still the way in clinical practice. It is difficult with certainty to determine in some patients whether the manifestation is a feature of lupus or not. When you apply these attribution rules, in this case, the SLIC attribution rules, you now get a more slender pie diagram, if you like, because we've removed headache, we removed anxiety, we removed some other manifestations, but the most common feature now are mood disorders, seizures, cerebrovascular disease, cognitive dysfunction, and the other features as shown on the pie diagram. So if you look over the first 5 years of disease, you can see that of the 47% of patients who have some nervous system event, 39% of those patients, it's not due to lupus. Or if you look at it as a number of events, out of 100 events, only about a third of them, or 31%, are attributable to lupus. So the majority of the overall events that occur in our patients are not due to lupus. The other way of looking at this, or the other aspect of this, is shown on this diagram. Let me just tell you, this is what's called a lasagna plot. And on your left are the nervous system manifestations attributed to lupus, and on the right, the nervous system events not attributed to lupus. The red color indicates onset of a new event, and the blue color indicates a resolved event. So what the slide is telling us is that most of these events occur early in the disease. As you come down along the stairs, you can see that the color density is less. So these events are occurring later in disease, but they are fewer in number. So again, as with other features of lupus, including lupus nephritis, nervous system disease tends to occur early in the course. But whenever it occurs, and regardless of attribution, it does have an impact on patients' self-reported health-related quality of life. So here we're looking at the SF-36 summary scores on the top half of the slide. The spidergram at the bottom shows the changes in the individual subscales of the SF-36. And if you take the triplet of bar graphs, what it tells us is that patients without nervous system disease have a relatively good score on the self-reported quality of life. This falls during an event, and then when the events are resolved, the self-reported quality of life improves. And this has been a consistent finding through all of the studies that we've done with the SLIC cohort, that there is a reversible impact on patients' perception of health-related quality of life. Now, this is not a failure of the technology. This is meant to indicate a typical day in Halifax, Nova Scotia, maybe sometimes in Bordeaux, where you have a lot of fog. But if you're a patient with lupus, you'll recall it lupus fog. And this is a term that's sometimes used by patients, at least, to identify problems with cognition, which is our ability to process information, to recall things, to multitask, to pay attention during boring lectures, especially. And this can be determined in a number of ways. There are really very few good screening techniques from the point of view of questionnaires. And the gold standard remains a formal neuropsychological assessment in collaboration with neuropsychologists. Computerized neuropsychological techniques have been developed, such as ANAM, which has been used, and we have used that as well. And it does tend to correlate with what is found with the more formal type of testing. What you're aiming at here is some overall assessment of cognition or looking at individual domains of cognition. And as I say, the components here are memory, concentration, executive function, or multitasking. Virtually every study that has looked at this in clinical cohorts of patients have found that lupus patients have a higher frequency of some form of cognitive impairment compared to either normal controls or disease controls. The frequency is around 35 to 45% of patients, and there's a relative risk compared to, say, patients with RA of almost 2, and a relative risk compared to healthy controls of almost 3. So it is present, it's reproducibly found, and it is quite frequent. This rather complex slide makes the point that many different domains of cognition are affected in lupus patients, but these deficits are relatively mild and subtle. You can take the G or the Hedges G score here as a standard deviation. So these are not major deficits. And over time, they tend to fluctuate. So it is not like a patient who is at the early stage of a vascular dementia or Alzheimer's disease where there is a relentless progression over time. In lupus patients, even over a 10-year period, as in this study here, which was the longest study done in this particular aspect of lupus, the deficits tend to be evanescent. So between time 0 and time 1, they remain mild to moderate. The frequency actually falls over time. And so you can see 40% of patients had no change, but 50% showed improvement and only 10% showed deterioration. These are still important problems for patients, but this is the course they tend to run, which raises some difficulties with regards to their study and particularly to the treatment. So to summarize this part of the presentation, the events that occur in lupus patients are diverse. Overall, the majority of nervous system events are not attributed to lupus, but about a third are. They tend to occur early in the disease and have a negative impact on health-related quality of life. And this has implications then for both the treatment and the study of pathogenesis. So I've told you that these events, whether they cause focal nervous system disease, such as stroke, or diffuse nervous system disease, such as cognitive problems, are often not due to lupus. But the features or the mechanisms by which lupus contributes to these events can include a vasculopathy, families of autoantibodies, and inflammatory mediators. Now, I cannot go into all of these in any detail, or at least I choose not to, but in general, I tend to think of these, and this has been proposed by others as well, as these coming together to form two separate pathogenic pathways. There's an ischemic pathway where antiphospholipid antibodies, immune complexes, and possibly complement activation are involved, giving rise to thrombosis or microangiopathy. And we see this manifested clinically through focal events such as stroke, or diffuse events such as cognitive impairment. If you have enough small vessel disease, then you can end up with some cognitive deficits. Perhaps the more intriguing pathway is an inflammatory pathway, where the mediators are again autoantibodies, various inflammatory mediators, including complement again. And the mechanism here is one of impairment of the blood-brain barrier, allowing access of circulating proteins, including autoantibodies, into the CSF space, causing the formation of immune complexes and activation of plasmacytoid dendritic cells, and then downstream effects from microglial activation and synaptic pruning. And this gives rise to predominantly diffuse nervous system events such as psychosis, or again, cognitive dysfunction. Brain is a highly vascular organ. It is important, therefore, that there is a robust regulatory mechanism or mechanisms in place to provide the correct homeostasis for the brain to survive. And this is what gives rise, recognized as the blood-brain barrier. It's a structural and functional barrier that protects us from our circulation, essentially. And it is highly structured with these tight endothelial junctions. Astrocytes play a role and help to regulate with neuronal cells what gets in and what gets out of the CSF. We have done some studies recently at our center using some advanced MRI neuroimaging techniques to assess both the blood-brain barrier and the consequences or the linkage with functional connectivity. So these were patients attending our own lupus clinic, and we had some healthy controls. We looked at cognition using neuropsychological assessment techniques to identify deficits in areas of cognition that are well known to occur or to be affected in lupus patients. And then we used two techniques, which I'll tell you a little bit about, looking at blood-brain barrier and functional connectivity. So these are some representative scans using a technique called dynamic contrast enhanced, or DCE MRI, to look at blood-brain barrier permeability. The three individuals on your extreme left are normal controls. The three in the middle are lupus patients with normal blood-brain barrier function, and the three on your extreme right shows three patients with lupus where you can see more red appearing, and the more red you see, the more permeable the blood-brain barrier. This can be quantified, and when we did that, we found that 9.1% of total brain could be affected in this way in a healthy control, but above this, we identified it as extensive blood-brain barrier permeability. And this occurred in about 26% of our lupus patients, as shown here on the extreme right. When we looked at these results in the context of cognitive function, which was tested on the same day as the scanning, those patients who had extensive blood-brain barrier, shown here in red, showed a reduced ability of cognition. And this reached statistical significance if you looked at overall cognition, or if you looked at impairment in more than one particular cognitive test. So we then wanted to see if there was a connection between blood-brain barrier permeability, which we knew now was linked to cognitive impairment, and functional connectivity. Now, functional connectivity, it took me about a year to understand what the neuroimaging people were talking about. I mean, so I've simplified it here in a non-expert or a HANLY guide to functional MRI. If there are imaging experts in the audience, I apologize, but this is the only way I can explain it and understand it. So first of all, functional MRI essentially is an indirect measure of neuronal activity by measuring the amount of oxygen in the blood in a particular voxel or area of the brain. Functional MRI is used to assess either a resting state or a task-based MRI. So a resting state is when you're lying in the scanner, not thinking of anything. Task-based, you're asked to solve a puzzle. The brain never rests, however. It's never totally quiet. There's always things going on. So it really should be called a non-resting, a non-activity state, but it's called resting MRI. Functional MRI uses this information to essentially assess statistically the correlation between simultaneous neuronal activity in different anatomical areas of the brain. So it's really a correlation of activity, neuronal activity in different regions of the brain. You can have positive functional connectivity where there is mutually synchronized activation in different regions, sometimes called positive correlation, or negative functional connectivity or negative correlation where there is reciprocal deactivation between regions. So when one region is active, the other is resting. Why is this important? Well, synchronization of neuronal activity is the basis of integrating brain regions into networks, because the brain essentially is a great big network from a functional point of view that perform higher brain functions, including cognition. Okay, so this is my interpretation of functional connectivity. This would make a lovely piece of art, I think, and I must get this framed from my office someday. But this is our initial findings of altered functional connectivity between lupus patients who had normal cognition and lupus patients who had cognitive impairment. And what these dots and lines joining them show us is that this is the difference in the functional connectivity between these two groups. And it is essentially everywhere you see a yellow line, it indicates that there is reduced negative functional connectivity in different so-called canonical resting state networks. Okay, so there are known resting state networks that's shown here on the right of the slide, and then these are nodes or regions of interest in different parts of the brain where there is reduced negative functional connectivity. When you quantify this by looking at the mean functional connectivity for each individual patient, and again, you look at it for healthy controls on your left, SLE patients with normal cognition in the middle, and SLE patients with cognitive impairment, you find there are group differences. And essentially what you're looking at here is a change in the correlation between the different brain regions. And the correlation shown on the vertical axis, you can see that the lupus patients with cognitive impairment are higher. So they're closer to zero, or in some cases even into the area of positive functional connectivity compared to lupus patients with normal cognition and healthy controls. So there are differences here when you segregate your population on a clinical basis, on the basis of cognitive performance. We then wanted to look to see if there was an association between functional connectivity and blood-brain barrier. And here we've segregated the group into those patients with normal blood-brain barrier shown in panel A on your left versus those with extensive blood-brain barrier permeability, examples of which I showed you in an earlier slide. And again, you can see the same change, that those patients with enhanced blood-brain barrier permeability have a higher correlation, closer to zero or even to positive correlation compared to those patients with normal cognition. And when you look at the degree of blood-brain barrier permeability, the higher the permeability, the higher this correlation goes, or the further the loss of negative functional connectivity. This is illustrated here on some individual cases. So we're looking at 5 patients here. Let me see my, I guess you can't see the cursor. So if you go from the top to the bottom, this is a representative DC MRI scan of a healthy control on the top. Next one down is a lupus patient with normal blood-brain barrier function. And then you have 3 lupus patients with increasing blood-brain barrier permeability. You'll see more red coming into the scan. On the right of the slide, we're looking at the bold signal. Okay, this is the MRI signal, functional MRI signal for 2 nodes. Okay, represented by the 2 different colors. And then you'll see an R value, which goes from negative to positive as you come from the top down. And if you just compare the top patient scan with the bottom, you'll see that the course of the colored lines gets closer together. In other words, they get a closer synchronization. Okay, so that the more permeabilized the blood-brain barrier is, the closer these signals are to each other in a very synchronized way. Okay, and when we applied some causal mediation analysis to this to determine how much of the association we saw between blood-brain barrier permeability and cognitive impairment was mediated through abnormalities in functional connectivity, we found that 64% of it, so highly significant, was mediated in this way. So the pattern of this mechanism is that the blood-brain barrier is impaired. That then leads to an abnormality in functional connectivity, which may be compensatory in some ways, which then is translated clinically or associated clinically with cognitive impairment. Okay, now this is a cross-sectional study, so we would have to be reproduced and have to be reproduced with a longitudinal study. But this brings together the different components of what we've seen in neuroimaging, and I think provides a nice story, if nothing else. So let me just switch gears now and go back to more clinically based issues. How are patients with nervous system disease, particularly people with nervous system disease attributed to lupus, what is the treatment algorithm? Well, I always say to our residents, if you're asked to see a patient and the question is, does this patient have CNS lupus? The first question you should ask is, does the patient have lupus? And that'll get you out of all sorts of problems because often a positive ANA and a seizure may be called by some people CNS lupus, but you really have to be sure that this patient has lupus. If the patient has lupus and a nervous system event, the next question is it due to lupus or is it due to something else? Okay, and if it's due to something else, and sometimes it can be due to both, but if it is due to lupus, is the process still active? Is it something that requires treatment, or are we just looking at the legacy of disease activity and the consequences of damage? Apart from your clinical acumen, there are some things that one can consider to help confirm the diagnosis. There are different families of autoantibodies. In particular, antiphospholipid antibodies will be important in the context of focal disease, if there's any suspicion of ischemia as a disease mechanism or thrombosis. Sampling the CSF is largely done to exclude infection. There are other interesting things that one can do with it, but that's from a clinical point of view, that's the main reason for sampling the CSF. Obviously, if there are concerns about peripheral nervous system disease, nerve conduction studies will be important. Neuropsychological assessment is required if you or sometimes the patient is particularly concerned about the issue of cognition. And then in neuroimaging, select a method that tells you something about brain structure and brain function. And I've shown you some of the two more advanced techniques for assessing brain function. Once that determination has been made, one should always look for non-SLE factors. High blood pressure is bad for many organs, including the brain, so that needs to be treated. Obviously, infection should be treated. If there are metabolic abnormalities, that may need to be treated. Symptomatic therapies, including anticonvulsants in the early stages of a seizure disorder may be required, or mood disorders. All of these things will work just as well in lupus patients as in those patients without lupus. But then we come to the more specific lupus-related therapies. If it's a focal nervous system event, the role of immunosuppression is really not well supported. It is really a matter of some form of anticoagulation, whether that's gentle anticoagulation with antiplatelet agents or full-blown anticoagulation with warfarin or heparin. And the treatment of diffuse manifestations, it really is derived from the treatment of other inflammatory disease states in lupus, such as lupus nephritis with high-dose corticosteroids, and then whatever immunosuppressive therapy you wish to use. All of these have support from observational studies, but very few have been subjected to randomized placebo-controlled trials. Let me finish now by showing you some outcome data, and this will come from the SLIC inception cohort. This was an early study where we looked at the outcome of nervous system events using a simple Likert scale in patients with SLE attributed, with neuropsychiatric disease attributed to lupus with model A or model B versus non-SLE neuropsychiatric events. And what you'll see is for model A and model B, the blue bar, which is showing resolution, was higher than for the non-SLE related events. And this is held true in all of our studies, even with long-term outcome. And that is that with nervous system events attributed to lupus, they often will have a better outcome with current standard of care. This is looking at them in totality. If we look at some individual manifestations, and headache being a common form, we looked at this in a separate analysis. We found that whether you look at resolution or you look at the individual types of headaches, most of these will resolve over a reasonable period of time. And the issue always comes up, is there something called lupus headache? This is somewhat controversial, and I'll tell you what side of the argument I come down on in a minute. But if you want to pick a definition of lupus headache, this is taken from the SLEDAI, severe persistent headache, which could be migrainous, non-responsive to narcotic analgesics. When we looked within the SLIC inception cohort, we found that the identification of lupus headache in the SLEDAI was a very infrequent occurrence, only 1.5% of patients, or less than 0.5% of total events. So-called lupus experts weren't identifying it very often. Concurrently, we assessed headache using the International Headache Society's classification and didn't find that there was a unique type of headache that matched or linked up to these recognized events. They could be migrainous, they could be tension headaches. Relatively few of them were identified as intractable, non-specific headaches. And so in the editorial written by Michael Lockshin that accompanied this paper, he suggested that headache should actually be dropped from the SLEDAI, and other people have suggested that as well. And he entitled this editorial "Splitting Headache," which I thought was kind of cute. Seizure disorders occurred in just under 5% of patients in an early publication from the SLIC cohort. And again, when we looked at these with regards to attribution, those events which were attributed to lupus were more likely to resolve, not recur, not require long-term anti-seizure medications compared to patients who had seizures for other reasons. Cerebrovascular events, again, occurred in just under 5%. The majority of these were attributed to lupus. And whether you looked at resolution or you looked at the total outcome using the full Likert scale, these events in the majority of patients had a pretty good outcome. And then finally, psychosis, which is a rare but quite dramatic manifestation of lupus, only occurred in 1.5% of our patients. The majority of them, these events were attributed to lupus, and 80% of these events had resolved by the second annual assessment after their onset. This is shown here by resolution assessed by a physician and the SF-36 scores in the spidergram showing the scores before and after the resolution of the psychotic episode. And this has been shown over a more prolonged period of time. David Eisenberg has published a follow-up study over 20 years showing that in general, if patients get over their first psychotic event, they tend to do well without recurrence. So to summarize, what I hope I've convinced you is that nervous system disease in SLE patients consists of both common things such as headache, rare events such as psychosis. Attribution suggests that 1/3 of the total NP events are due to lupus, and that these may be the ones that have the best outcome. There are different immunopathogenic pathways, ischemic and inflammatory. We didn't go into these in any great detail. I think neuroimaging does hold some promise from the point of view of helping us to better understand what is going on in these patients, and hopefully to help us to identify those who can be treated in different ways. But we certainly need inclusion of more patients in clinical trials to determine both symptomatic therapies and anticoagulant and immunosuppressive, including biologic therapies in our patients. To return to lupus fog, we have a fair amount of fog in Halifax, as our patients do, but in Halifax, when summer comes around, the scenery changes. This is a photograph taken from our own house in Halifax. So I think both in the weather and hopefully in our lupus patients, the fog is beginning to clear and the future is bright. I'd like to thank and acknowledge my own colleagues in Halifax who have been tremendously supportive to me over the years in doing some of this work. All of the colleagues in the SLIC network, and particularly the patients who have participated so generously in our studies, and the Canadian Institutes of Health Research for core funding. And thank you very much for your attention.
Thank you. Nice speech. Vous avez des questions peut-être quand même? Même si on est en retard.
Thank you, John. That's a very outstanding talk. I have a question about your MRI data. So you compare most of the data to LC control. Did you have you compare the MRI data from systemic lupus patient to LC donor, LC control?
Yes.
And did you get a chance to compare the data to a patient with viral infection, like such as flu or COVID-19? Because I think a lot of us experience COVID-19 infection and they got a kind of fog. So I'm wondering if that could be the same kind of mechanisms.
So we haven't done that, although there are colleagues who are looking at this, particularly in the context of long COVID, so-called long COVID. But I'm sure you're right, Christophe, that this is not unique to lupus. And in fact, the person who I've worked with in this area, Alon Friedman, has made an entire career out of looking at the blood-brain barrier. And he has shown some very dramatic changes in football players, young athletes who come off the field and you do this and they have scary looking scans. They did some work even in something called the Havana syndrome. I don't know if you read about this, where these people in Havana, in Cuba, had these very strange sort of fog type symptoms, and there's a long story there. So I'm sure you're correct that if you looked at this in the context of someone who had a viral infection, that you would find changes quite similar to this. One of the things, so for example, one of the other groups in Halifax has looked at this in this scanning technique in the context of bipolar disorder. And they have found that in that situation, that is a particular area of the brain. It's a very focal permeabilization of the blood-brain barrier. One of the things you may have noticed on the scans I showed you from our lupus patients is that it's a very diffuse process. No two scans, they're abnormal, but it's a very diffuse process, which probably fits with the way we think of lupus, that if it's a microangiopathy of some sort, it isn't picking out one area of the brain necessarily, it's affecting multiple areas. So this is a phenomenon that I think probably applies to a lot of situations. People with epilepsy as well will have these abnormalities.
Thank you very much for the amazing talk. This is 40 years of research integrated in 40 minutes. So that was a big, amazing challenge. I have a question about the attribution of mood events, because I think this is really difficult. We saw that this is the #1 type of event that is attributed to SLE. Right. How do you manage to say this is SLE or this is not SLE in the context of mood events? There are attribution rules, but I think it's always very tricky. Yeah. Is this the underlying pathogenesis of lupus that is responsible for the mood event? Or is this the simultaneous onset of lupus with the impact in life?
Yes, so I mean, that's an excellent question. And to be honest, I don't really know the answer. I mean, when we developed these attribution rules, we did it in a systematic way using, you'll recall that there were the 3 things we did was the timing of the event related to the diagnosis of lupus, whether or not there were, for each of the 19 manifestations that are identified in those ACR case definitions, there are a number of things to be considered that as an alternative case. And then we excluded, certain things that are very common in the general population, such as mild mood disorders, mild cognitive impairment, etc. But in truth, in an individual patient, unless there's something very obvious as an alternative cause, like a bereavement in the family or a loss of employment or something, it is very difficult. And the same applies to the cognitive issues. And one of the hopes, one of the dreams I have is that the neuroimaging data that I've shown you may help us to identify those patients with cognitive abnormalities, for example, and you could apply the same to mood disorders, who have an abnormality that we can link to lupus. Because in those patients that we studied, we didn't try to exclude anybody. So we have everybody in there with cognitive difficulties, only some of which are due to lupus. And that's why it wasn't 100%. We only had about 48, 50% of, sorry, yeah, about, if you look at the, only 26% of the total population, about 40% of the people with cognitive impairment had those abnormalities. So there are probably people in there who have cognitive difficulties for other reasons. So I think it's going to be very difficult with the current, just using our clinical acumen to know for certainty whether things like mood disorders or even cognitive difficulties are due to lupus or not. Yeah.
Thank you, John, for this very fascinating presentation. Regarding your MRI findings, what would you expect when you are to treat by the patient? And do you have some kind of longitudinal follow-up in those patients before and after some treatment? And as soon as you have those kind of observation, is it something which is fixed or can we back up?
Well, they're all excellent questions, and I cannot answer any because we haven't done those studies. I mean, this is the functional connectivity paper is currently under review. And I think it probably will be accepted with some revision. So but we have not, that is the next phase. I mean, I really don't know whether these are reversible or not. My suspicion is that it depends on the patient. Some patients, I suspect, may have fixed abnormalities. These may be people who've had recurrent minor strokes, thrombotic disease, and there are some people who I think probably have reversible abnormalities, but we need to do those longitudinal studies. And then, of course, it gets more interesting. Is there a way in which we can manipulate this and show clinical benefit? So at least in our hands, we're at a very early stage in this, and a lot more work needs to be done by somebody.
Yeah, I have one question. So thank you for your talk. And in your daily clinical practice, how do you investigate these patients? What kind of tests you perform? The imaging, do you perform functional MRI for everybody? And do you do analysis of CSF? Do you do lumbar puncture for some of them?
Is your question specifically about people with cognitive issues or any manifestation?
Any neurological manifestation?
Well, I think it depends what the manifestation is. I mean, somebody who comes in who is very ill, who has a diminished level of consciousness, for example, a very severe manifestation, you really have to pull out all the stops. And in that situation, first and foremost, you have to exclude some other cause, particularly infection. So that would include tapping CSF, doing any form of, whatever form of neuroimaging is available to you, and then proceeding with some sort of treatment algorithm. It's very difficult. I mean, the list of investigations that I gave you there is the full list, and then that would be tailored according to what the particular problem is. Somebody who comes with, during a routine clinic visit and has memory difficulties, which is reinforced and supported by a family member or spouse, which is becoming more than what they would normally expect, I would, make a referral to my neuropsychologist who would see the patient in due course and do neuropsychometric testing. And I may do an MRI scan as well, but I wouldn't subject that person to a lumbar puncture, for example. I would assess their overall disease activity. So it is probably, it has to be tailored more so than, say, the investigation of lupus nephritis, where you're going to look at the serology, you're going to look at the urine, and you may do a renal biopsy, yeah, and an ultrasound. I mean, you could probably do that with every patient, but for the nervous system, I think it has to be more nuanced, more subtle, and more tailored according to whatever the manifestation you're investigating.
Do you think that isotopic scintigraphy imagery, such as in Parkinson's disease, could be an help in the management of this patient?
Scintigraphy?
Yes.
You mean, you're talking about PET scanning?
Yes.
Well, there have been a few publications on PET scanning, which has had some positive outcomes. We haven't looked at that ourselves. I think SPECT scanning, although there have been some studies, I'm not a big fan of that. I think there's often a mismatch between what shows up on SPECT scans, and this is using just a regular neuroisotope, the SPECT scan and what is seen clinically. So we certainly haven't used that, and we haven't availed of, well, we haven't had access to PET scanning. It's a more difficult technique for us to get access to.
And in your center, do you use functional MRI routinely?
No.
No?
This is purely, this is an investigative technique at this stage. I mean, the actual scan itself doesn't take long to do. Well, for the two studies I've shown you, it takes an hour. The patient has to be in the scanner for an hour. The patients are amazing what they do. I mean, it's not easy. I've been in an MRI scanner. I don't think I could stay in there for an hour. But what is incredibly labor intensive is the amount of processing that these are huge data files, and they have to be pre-processed and manipulated in all sorts of ways before you come up with those neat little squiggles. I mean, it isn't a clinical tool at this stage. We're still learning.
Well, thank you very much.
Thank you.
Speak simply.